can include, in this case, occurrence of a PPH event, both mild and moderate and severe, quality of life issues related to disability, or mortality, which can also happen in this case. So combining both the health outcomes and cost uh, in an economic model and analyzing them holistically leads us to the evidence related to cost effectiveness analysis. And then the decision maker can use that can use that evidence to make an informed decision about deciding whether the intervention is good, it gets the highest value for their money in a resource limited environment, which is healthcare in general. Next slide, please. So our presentation today, we are going to be presenting our cost effectiveness analysis, in which we are looking at heat stable carbetocin and comparing it against different existing treatment. And just to show you the magnitude of the holistic assessment, our model takes into account in total of 285 parameters related to general inputs, clinical inputs, as well as economic inputs, and then analyzes them through our economic model, which is a decision tree model in this case, and gives us the evidence on cost effectiveness of heat stable carbetocin. Next slide, please. So now we're going to be looking at the specifics of this analysis. So the objective again for this analysis is to inform decision makers on potential integration of a novel ether tonic into country programming. Our economic model allows for integration of different treatments, as well as health outcomes and costs, as I mentioned in my earlier slide, associated with PPH due to uterine atony. The economic model also allows us to conduct cost effectiveness analysis of heat stable carbetocin compared to other ether tonics, which we'll go through later on for PPH prevention. And as we already mentioned, heat stable carbetocin in this case is the newest recognized ether tonic for PPH prevention and will be evaluated against all the other existing treatment options. And then finally, the model allows us to explore different hypothetical scenarios by the way of conducting sensitivity analysis on those different scenarios. Next slide, please. So now we're going to look at the model structure. And before we go there, we just would like to make people aware that we are using India as a use case in this analysis. So this is how this is what the model looks like. I can walk everyone through the model quickly. So it starts with women who are going to deliver, and then they will be categorized into two different categories under vaginal birth as well as C-section birth. And then once they're categorized, they will be administered either a prophylactic heat stable carbetocin or a prophylactic comparator. Depending on what drug you're administered, then you either go retreatment with additional ether tonic depending on the need, or there is no need for retreatment. And then they further move into a node where there's a probability of a severe PPH event happening, or a mild to moderate PPH event happening, or no PPH event happening. And then finally, the women are allowed to exit the model either being alive or dead. And the same things happen for each of the other comparator in the model. Next slide, please. Now looking at the perspective and population for this analysis. So we analyzed the cost effectiveness from a public healthcare system perspective, in this case, the Indian healthcare system. So we are looking at the data from a central or state government's perspective, as well as hospital administrators' perspective. And as I mentioned, India was the use case, but this model is very readily adaptable to other low and middle income countries. We are only looking at direct costs, which are relevant to the healthcare system. So that will include costs related to the drugs, administration, healthcare resource utilization associated with PPH prevention, follow-up and cold chain costs and such. Adverse events associated with uterotonics were not modeled in this model. We look at pregnant women in the third stage of labor while undergoing delivery in public health facilities. And as I showed on the model structure, the women are divided into cesarean and vaginal delivery groups as well. And then also we look at a subgroup for women who have anemia. The model also accounts for quality concerns with oxytocin. So now here are the comparators against which the heat stable carbetocin, which is the newest recognized uterotonic, is compared against. So we are comparing it against oxytocin, misoprostol, and a combination of oxytocin and misoprostol. Next slide. So now let's go over the input for this analysis. So there are three different categories of input in this model. So first, the general input, where we input all the data related to the population and the healthcare setting. The clinical input category includes different uterotonics as well as their recommended dosing, the efficacy of each of the uterotonics, PPH management, disability, so the quality of life associated with disability caused due to PPH, and then finally mortality. And then lastly, the economic inputs, which include drug and drug administration costs, any healthcare resource use costs which are associated with PPH, as well as cold chain costs. Next slide, please. So in interest of time, we can't go over all the different data inputs because it'll take us longer than the assigned time. So we thought we'll just give you examples of some of the key inputs which will be relevant to this audience. So in terms of general input, we can show you the proportion of C-section births. So the data, as you can see on your screen, comes from the National Family Health Survey conducted by Government of India in 2017. And it was the estimate was used as 11.9%. The example for clinical input, so we looked at risk of mortality as per the location of healthcare setting. So as you can see on your screen, that data comes from published literature. And we can see the odds ratio associated with primary, secondary, and tertiary healthcare, so which you can see that the odds of mortality or the risk of mortality was a little over twice associated with primary healthcare setting compared to the tertiary healthcare setting. And then finally, an example of the economic input. So you can see on your screen, we use the cost of blood transfusion per unit blood. And again, it was different, or it was divided into primary, secondary, and tertiary healthcare setting. The cost in primary and secondary healthcare setting was found to be the same, and then the tertiary healthcare setting was slightly more expensive than the primary and secondary healthcare setting cost. So the cost for tertiary healthcare setting for cost of blood transfusion in a tertiary healthcare setting was around 1,600 Indian national rupee. And in the dollar amount or US dollar amount, it was found to be around $22.41. And since this data we could not find in a government record or published literature, so we used the help of Indian KOLs in this case. Now looking at the results of this analysis, so this is how a conventional cost effectiveness analysis result table looks like. So you look at all the treatment options which were evaluated in the model. So in this case, we have heat stable carbetocin, oxytocin, oxy-meso combination treatment, as well as meso only. Then we'll look at total costs associated with each of the treatment options. Then the incremental cost, which is essentially the difference or additional costs associated with each of those existing treatment options compared to heat stable carbetocin, and the same goes for effectiveness and incremental effectiveness. And then finally, we look at the incremental cost effectiveness ratio, which is the primary outcome of a cost effectiveness analysis. So now the first set of results, we look at the total and incremental cost. And again, this is a base case result for a cohort of 1 million women, because as I mentioned, India is a use case. So we assumed the cohort of 1 million women to sort of reflect the real world population in India, which will be going through this model. So I can walk you through the results in this table. So as you can see on the first column, we have the 4 treatment options which were evaluated. The second column shows all the total costs associated with each of the treatment options. The third column shows the incremental costs or the difference of each of the existing heterotonic against heat-stable carbetocin. And then finally, the difference is reflected in a percentage amount. So as we could see, the difference, can you go back, Jeff?
Yeah.
As you could see, the difference ranged from 1.2% to 3% higher cost associated with oxytocin, oxymeso, misoprostol compared to heat-stable carbetocin. So heat-stable carbetocin essentially was associated with lower total costs compared to oxytocin, oxymeso, and misoprostol. And in the dollar amount, this total cost difference is reflected on your extreme right of the slide, where we can see the incremental cost difference amounted from $1.6 million to 3.9 or almost $4 million additional costs compared to heat-stable carbetocin. Now, looking at one of the effectiveness measures, again, in the base case result for a cohort of 1 million women in India. So here are the total PPH events associated with each of the treatment options. Can you click one more time? Thank you. So again, as the previous slide showed, you have the effectiveness, all PPH events associated with each of the treatment options, the incremental effectiveness, which is essentially the difference between the existing treatment option against heat-stable carbetocin, and the difference in percentage amount. So as you could see, the additional all PPH events associated with oxytocin, oxymeso, and misoprostol amounted to around 38,630 all PPH events to 71,788 all PPH events higher than heat-stable carbetocin. So essentially, heat-stable carbetocin was associated with lower total PPH events compared to oxytocin, oxymeso, and misoprostol. Next slide, please. Now, looking at a subset of the earlier result, which is looking at only severe PPH events. So the earlier slide, we saw the results for all PPH events. So now we are going to look at severe PPH events in this population. So as we can see, the total severe PPH events associated with each of the 4 treatment options in the second column, and then the incremental effectiveness results or incremental severe PPH events associated with oxytocin, oxymeso, and misoprostol. And we can see on the screen the additional severe PPH events range from 8,316 to around 27,000 severe PPH events compared to heat-stable carbetocin. So essentially, heat-stable carbetocin was associated with lower severe PPH events versus oxytocin, oxymeso, and misoprostol. So these, so now finally looking at the ICER results, which is the primary outcome of this analysis. So as we saw from the cost and effectiveness outcomes in this base case, in this scenario where we are looking at 1 million women in India who undergo treatment with either of the 4 heterotonic options, heat-stable carbetocin was found to be dominant against the other 3 options. When I say dominant, it essentially means that the intervention or the novel intervention was not only associated with lower total costs, but with better health outcomes. So it results in cost saving as well as shows clinical superiority over the other treatment options in this model. Next slide, please. So this is the final slide of the presentation where we just want to emphasize on some of the key takeaway messages. So effective PPH prevention, as you would all know, in this audience is the first line of defense at a population level to improve health outcomes and reduce costs. Heat stable carbetocin is cost effective. Is a cost-effective uterotonic for PPH prevention, as we saw in the results section, associated with lower total treatment costs and better health outcomes. And some of the key differences which lead to this better or favorable cost effectiveness include less additional uterotonic usage, less referral costs, reliable potency, and less cold chain costs, which include logistics, storage, and wastage costs. Sensitivity analysis results, we found the risk of mortality and duration of hospital stay to have the greatest impact on the results of cost effectiveness. After testing different scenarios in our analysis, we found that heat stable carbetocin was found to be most cost effective for PPH prevention in all but one analysis. Heat stable carbetocin thus warrants inclusion into country programming because it makes the health system more efficient and less burdensome. And lastly, heat stable carbetocin, as shown by this cost effectiveness analysis, can strengthen countries' response to PPH and support achievement of countries' SDG and USC goals. And we are happy to take any questions. Thank you for listening.
John, over to you.
Yeah, great. Thank you so much, Jeff and Kunal. A lot to cover in a short period of time, and I know a lot of effort is going into this modeling. And I think that it's in so much that we do, we look at purely at effectiveness, but having this health economic modeling, I think, is really important to help drive decision making. So I think this is really useful. We do have a couple of questions already in the Q&A, and I'm sure some will be additional ones will be coming in. We'll start with Mika Dinev, who asked, in the effectiveness representation, what do the numbers represent? Is it dollars?
So in the effectiveness slide, so we showed two effectiveness results. The first one was the all PPH events. So the numbers on the slide for all PPH events. So the second column, these are all PPH events which were observed in the women who were undergoing treatment with heat stable carbetocin, oxytocin, oxymeso, and misoprostol. And the difference is essentially the additional, as you can just, subtract all PPH events associated with oxytocin by heat stable carbetocin, and you'll get the 51,845 additional all PPH events. And similarly, it goes the same for oxymeso and misoprostol. So these are all PPH events, not the dollar amount. That was shown in the cost slide, total cost slide.
Okay, great. Next question is from Debbie Armbruster. If you recognize that oxytocin will still need to be procured related to use for treatment, induction, augmentation, the cold chain and some of the other costs will still be required. Have you taken this into account? Have you taken into account that both medications will still be needed?
Jeff, do you want to take a stab, or do you want me to go ahead with that?
Why don't you lead now?
Okay, so yes, we definitely acknowledge and recognize that both, the cold chain cost will be needed because both drugs will be needed, and we are only looking at PPH prevention. We only model PPH prevention here. The other, aspects or other procedures on the spectrum, definitely oxytocin will be needed there. But for the PPH prevention, I think we did account for those costs, in the model, which are like cold chain specific costs, because we do recognize that oxytocin will be needed there.
I would just add, Deb, that so the model allows and has various assumptions and allows for keeping or removing a particular assumption. So XYZ country doesn't want to include cost of cold chain, it can be removed from the model. But we understand the point you're making. Wastage is an area that likely will be relevant entirely. Things like transport, etc. Partially relevant, right? Cold boxes and things like that, and you might need less, etc. So again, we think that heat stable carbetocin helps lower the burden on an already stretched cold chain, rather than obviously replacing it in entirety.
Yeah.
Great. This next question is about the accounting for quality. Great presentation. This is from Pete from Monash. It's a great presentation. Jeff and Kunal, Monash, have conducted some similar work in relation to inhaled oxytocin to be published soon. We had difficulty accounting for oxytocin quality as there is little data on how reduction in quality impacts efficacy. Could you elaborate a little or how you handled this? Thanks.
Jeff, I'll let you lead this.
Sure. So good question, Pete. And we went back and forth on how best to handle this. The way that, in the end, the way we did it was we looked at behaviors. And so the model actually uses literature that suggests, based on observational data, as well as anecdotal data, that many providers are compensating for what they believe is poor quality in their hands by adding additional doses. So this model, in the base case, actually utilizes 17 IU as the base case for oxytocin dosing because of literature that suggests that, again, that providers are more than nearly doubling the dose because of this issue of quality. Not an easy question. Again, you have to make assumptions. We made that assumption for this model, as mentioned in my response to Deb. We can shut that off and just use 10 IU if need be, if it's not a particular scenario in a country, but that's the way we've addressed it in this model.
Anything else that Kunal or good? Okay.
No, I think Jeff covered it very nicely.
Yeah.
I think we did account for the potency or the quality issues related to oxytocin by using the literature evidence and ended up using 17 IU instead of 10 IU, which is the recommended dose.
Yeah, and I guess that's where you get into when you're saying that this is India specific, and so each country is going to take their context, right?
Yep.
And that's how you build it into the model. Yeah,
Yep, absolutely.
Great. Yeah, great. And so this is from Uchena. Considering that a large proportion of deliveries happen at home in low-income countries, should community-level prevention of PPH be considered a separate healthcare setting, or was this considered as part of the PHC? In the India case, was the use of misoprostol as the only option in the setting included in the cost-effectiveness analysis?
Yeah, so it's a good question. So Kunal, I'll just say that we modeled public health facilities in part because of following the WHO guidance, in this case, around the utilization. Remember, we were trying to assess heat stable carbetocin as a new intervention compared. So, the guidance is for an injection, skilled birth attendant facility, and so largely speaking, we focused on facilities. In countries that offer the opportunity to have injection at community level, this could potentially be extended there. Yeah, but we focused on facilities.
Great. Next question is from Fernando Altabe. Thanks for the good presentation. Can you clarify from where the estimate of health effects come from?
Talking the efficacy data, correct, Fernando?
Yes, I think.
Kunal?
Yeah, so we, as I mentioned on that general input example slide, so we use variety of different sources. So we wanted to use different sources and more robust scientific sources because it is a data-driven analysis. So we use the effectiveness data wherever we could find it in the published peer-reviewed literature, and the recommendations or guidelines provided by the local healthcare system. In this case, will be the government of India, India's recommendation on the health outcomes, and wherever we could not find data which was either not in a peer-reviewed literature or in Government of India's guidelines, we use the opinion of KOLs or key opinion leaders in that local country.
And just to add, Fernando, and I would say that the base case to add to complement Kunal's commentary around different pieces of literature, but to the base case around efficacy that's used in the model is the uterotonic network meta-analysis, as WHO has drafted their recommendations based on that, and as this model was looking not only at vaginal birth but also cesarean section birth.
Great, thanks. And next question from Mary Ellen Stanton. Is there any difference between looking at severe PPH versus PPH events that was used in the model?
So when you say any difference, I'm assuming any difference in the events which are reported for severe PPH events and all PPH events? Is that the correct interpretation?
I think so, or kind of disaggregating them.
Yeah,
so
so
at the effective,
yeah, so I think we showed that on our slides. So the first slide was all PPH events, and you could see there were like different number of events on this slide, because this is like the overall all PPH events associated with each of the treatment intervention. And the next slide shows a subset of those results where we only look at severe PPH events. And then this is the results. These are the number of events associated with each of the treatment intervention, and these are only severe PPH events. We also have results which are looking at mild to moderate PPH events and the other outcome measures. So we did disaggregate in terms of different outcomes.
Great. Next question from Jolie Belleza Cachesa. I hope I'm saying that close. Can carbetocin be used with oxytocin like oxytocin can be used with misoprostol?
Yep.
So I think I want to make sure I understand the question correctly. You're thinking about sequential use for prevention and then treatment. So I think so the regulatory approval for heat stable carbetocin is for prevention only. We know that at least in the CHAMPION trial that Dr. Dittmer presented yesterday, that those patients that went from the carbetocin arm that still had a PPH event, many of them went to other uterotonics like oxytocin, etc. That's probably the best answer that I can give.
Yeah, and I think that's right. So it's not like we're talking about like similar as like oxy and meso or oxy and ergometrin, that kind of combination. So I think we're talking about carbetocin primarily. It's for prevention, right? That's your primary fit. Great. This is no surprise to me that there's many questions. I kind of predicted this, and they keep coming. So we're going to keep going. I think we'll use the time because it's a lively discussion. So this comes from Daisy Ruto from Kenya. Thanks for an eye-opening presentation in this model. The differences noted in the different urotonics, for example, oxytocin is due to repeat treatment. Do we know up to how many repeat doses for oxytocin was accounted for? Or was it like, for example, was it just when we say repeat, is it just one repeat? Or how was that when because I guess you're factoring in the number of vials, right?
So the only way that I can answer the question, Daisy, is again, we use the efficacy data, including related to additional uterotonics that came from the uterotonic network meta-analysis from the Cochrane review. And they have some statistics in that paper that talk about additional uterotonics. So that's how it was modeled.
Great. We want to keep going, or I think we're just going to go toward them. We have about 4 more, but let's just do 4 more and then we'll finish. Those are left in the queue here. So this comes from Jeff Smith. Fascinating analysis Thank you. In accounting for the 17 IUs as a base dose, does this mean you assume that 2 vials are used since the remaining 3 IU from the second vial cannot be reused?
Yes, Jeff, yes.
Correct.
Yes.
That was a quick answer. Next is Nancy Kadula. Sorry, we understand some countries can procure at a lower cost while others cannot. Does the model cover all cost scenarios?
So the model focuses, as Kunal mentioned, the model focuses on public sector. And if I understand your correction.
So, I'm sorry, I skipped down. So it was a two-parter. So what cost did you use for carbetocin? So understand that's going to be cost differences by countries.
Yeah.
Sorry about that.
Yeah, no, so we use the price, the price statement that Ferring Pharmaceuticals has issued at 31 cents per ampule. That does not include logistics costs, et cetera, but that's what's in the model is 31 cents.
Great, and so this is from Tosin. Thanks for the presentation. Was there any difference in mortality as an event?
You know?
Yes, so I think we did observe some differences between the different treatment interventions in terms of mortality, and I think that's part of all the different outcomes we looked at into this analysis. So there were differences in mortality, there were differences all PPH events, severe PPH events. We also looked at quality of life associated with disability. So what if a patient who undergoes postpartum hemorrhage ends up being disabled, and then we have to account for their diminished quality of life. So we even looked at that outcome. So there were differences in all those outcomes associated with what treatment intervention you were on.
Okay, thanks. So 2 more questions, and it doesn't mean that the questions end. We can keep accepting them, and then you'll be able to answer them as we go forward. Fernando's back with another question. Can you clarify whether your inferences apply globally or specifically for births attended in the public sector of countries eligible for special access price?
So the model is flexible. Currently, we are because of the work that Merck for Mothers has been doing, we are focused on in this context. We've been focused on public sector, but the model is flexible. The inputs that Kunal talked about can be modified to really, at a minimum, any low and middle income country setting. I'd have to think strongly about it if it's useful, if some of the assumptions in there are relevant to developed countries. Obviously, the 17 IU is probably not, but it can be modeled certainly for low middle income countries.
Great, thanks. And the final question for this session, the others are still coming in, but we'll hold on to those. This is from Robin Churchill. So given the work on PPH bundles, have you thought about how you might use your economic modeling to assess HSC in the context of bundles versus bundles with oxytocin?
So go ahead, Kunal, I don't know if you want to address that.
Oh, I think I'll let you lead, okay, Jeff, because I'm not very familiar with the bundles here.
Yeah. So Robin, thanks for the question. I mean, so what we understand is that health economic modeling is increasingly becoming important as countries roll out UHC, right? And HTA, or health technology assessment processes and capacity building, are ongoing and being developed in a number of countries. This tool, we think, can actually help that as countries think about the packages of care that they are going to design and develop for their response as part of UHC around PPH. We think this model can help them consider what could potentially be included in the packages of care for that. Hopefully that helps address your question.
So I lied. We have one more. We're going to do one more. So this is from Damalola. Can carbetocin be used for PPH prevention after oxytocin has been used for induction augmentation?
Yeah, so it's a good question, and I'd just like to frame the question real quick. I mean, I think it's important. You know, we say, some of us say carbetocin. I think it's important to really qualify. It's the heat-stable version of carbetocin that we're talking about here. It's an important, as we talk about quality of uterotonics, et cetera, that in some of the previous sessions. But to the question, so again, all I can say is that it is indicated for prevention. We know that in the CHAMPION trial that WHO led, that there was a head-to-head trial in prevention, heat-stable carbetocin versus oxytocin. Excuse me. There was a significant amount of utilization of uterotonics in the induction and augmentation phase prior to the use of the prophylactic, and you saw the results that were published in the New England Journal of Medicine.
Okay, so that was a nice round of questions for this session. So really important discussion. And again, I love the health economic modeling, aspect of it. I think it is so important. And one of the things that I find really intriguing about this model is, again, that you just used India as an example, and so it's very context specific, and so it's looking at all of those angles. So great, thank you so much.
There are a number, John, just so you know, there are a number of countries already that have asked to make it this model their own, and so we have a number of countries, several countries that are already capturing data that will then be inputted into this model to make it specific to that particular country.
Yeah. Can you tell us what countries?
Sure. So Kenya is looking at it, Nigeria is looking at it, Uganda is looking at it, and all three of them have already started collecting data.
Okay, cool.